Dear all, it's a great pleasure for me to present you my 2 years work in this translational medicine. So basically my topic is a kind of a borderline topic between neurology and cardiology because I am investigating mainly the role of left atrial strain in neurocardiology. I work at the Heart and Vascular Centre of Semmelweis University as a PhD student and cardiology fellow, and in my everyday practice I can see that the detection of atrial fibrillation requires expensive prolonged monitoring, so that is why derives my mission that I would like to decrease the necessity of prolonged monitoring with the help of my research work. I have, in this translational medicine program, I have 2 specific goals. The one is examining baseline differences in left atrial deformation imaging parameters in patients developing atrial fibrillation in the future. And the other topic is the effect of high versus low mesh density device on left atrial strain in patients with patent foramen ovale. Here you can see the status of my first manuscript. It's under revision at a journal, at the 4th journal, I think, because yeah, it's the way of submitting a paper, I know, so that's why we are still waiting for decision. I would like to highlight some background information about my topic. As we all know, old age comes with comorbidities, and for example, left atrial dysfunction can be developed, and it results in left atrial remodeling, which can result in atrial cardiomyopathy. And we know that and the underlying cause for atrial fibrillation is atrial cardiomyopathy. And of course, we all know that during atrial fibrillation there is stasis in the left atrium, in the left atrial appendage, and it can result in cardioembolization. And until these days, the gold standard method of diagnosing atrial fibrillation is prolonged ECG monitoring, but it's very expensive, and among the cardiologists there is no clear consensus on the appropriate modality and duration time of this monitoring. So that is why derives our idea that we could use and implement a non-invasive yet sensitive method in the everyday practice to predict the occurrence of atrial fibrillation. It could be the assessment of left atrial remodeling using a left atrial strain analysis. So basically our aim was with this meta-analysis to limit the range of patients who need prolonged ECG monitoring. Here you can see my PICO framework. Our question was, is the decreased left atrial strain associated with the occurrence of atrial fibrillation? We examined the patients who were in the cardiology unit and had a 2-dimensional speckle tracking echocardiography exam, left atrial strain analysis. And we compared those who were detected with atrial fibrillation during follow-up and those who did not develop this arrhythmia during follow-up. And our outcomes were left atrial strain parameters, mainly global longitudinal atrial strain and contraction strain rate. Here you can see the flowchart of the selection, and at the end of the selection process, we had 6 eligible full texts for analysis. Now I would like to speak about my results. I don't know how you are familiar, so first I would like to show you that at the right lower side of the screen there is apical 4-chamber view echocardiographic movie, and it represents the left atrial strain analysis in practice. So we are encountering the left atrium, the endocardial border of the left atrium, and afterwards the software calculates the left atrial strain values. So coming back to my results, as you can see, there were 5 eligible full texts for global longitudinal atrial strain analysis, and we examined altogether about 500 patients, and you can see that those who developed atrial fibrillation during follow-up had already decreased left atrial strain during their baseline echocardiography exam. So already in sinus rhythm, the left atrial strain without the clinical manifestation of atrial fibrillation was already decreased. And we could also determine a prediction interval. and there was only one study which did not have a significant result, so it was a very great result. And afterwards, our second outcome was left atrial contraction strain rate. Here we had 3 eligible full texts, and afterwards we also found that left atrial contraction strain rate was decreased already in sinus rhythm at the baseline screening in those developing atrial fibrillation during follow-up. Now I would like to highlight some strengths and limitations about my work. It's a very novel topic, so that is why there are a few data and there were few eligible studies. And it is the first meta-analysis which highlights the importance of this promising diagnostic tool. But there are, of course, limitations like the different monitoring methods for atrial fibrillation detection, age, heterogeneity, and the low number of studies. Summarizing my results, I would like to tell some implications for practice and, of course, for future research. So we would like to select patients, we could select patients with this promising method who need prolonged heart rhythm monitoring, and maybe in a multifactorial model in the future we could also use this promising tool to select those who need anticoagulation immediately. And there is, of course, a huge implication for research, because cutoff values of left atrial strain parameters should be defined regarding the necessity of prolonged heart rhythm monitoring and anticoagulation, because our data was not strong enough to define these. So as concluded, we can say that there are significantly reduced left atrial strain parameters in those who develop atrial fibrillation. My second study is protocol of a single center randomized trial. We are investigating the effect of high versus low mesh density device on atrial strain in patients with patent foramen ovale. About half of all cryptogenic strokes are related to patent foramen ovale, and the PFO closure is superior to antiplatelet therapy only in these patients, but we know that after the first 2 months of the PFO closure, the incidence of atrial fibrillation increases, so it tells us that maybe both electrophysiological and mechanical changes can occur in the atria, but there is no recommendation regarding the PFO device type. So our aim is to compare the 2 different mesh density types of closure devices regarding electrophysiological and mechanical changes in the atria. Here you can see the process of the PFO closure, so the hole between the 2 atria will be closed with two sides of the device. Okay, here you can see our clinical question and PICO framework. We are investigating patients who were referred to PFO closure to our clinic and comparing the 2 different mesh density types and assessing change in left atrial strain as a primary outcome and developing atrial fibrillation as a secondary outcome. And here you can see the 2 arms, which I already mentioned, and also the outcomes. The primary outcome is, of course, also left atrial strain and the strain rate parameters with this 2-dimensional tracking echocardiography, strain analysis, and our main secondary outcomes are AF and recurrent stroke. I already did the protocol drafting and the sample size calculation and waiting for the whole writing of this article. I have quite much additional activities. I have 3 additional projects in cooperation with 2 in cooperation with the National Health for Neurology and Neurosurgery Institute. And it is one a prospective registry analysis, another one a registry building, and I am conducting a randomized control trial at the Heart and Vascular Centre of Semmelweis University. I have 3 TDK students. One already presented my first project at the TDK conference, and I have some conference presentations from the last year and from this year also, and I also won Best Poster Award and Best Presentation Award. Thank you for your attention, and I would like to end my presentation with my favorite quote: do not let fear keep you quiet, whatever it takes, find your voice, and when you do, feel the silence.
I would start with, did I understand well that you are trying to find people to start anticoagulation based on the atrial strain, even though they do not have yet atrial fibrillation?
No, it's a very, thank you for your question. It's a very, not in the near future, because we need data of randomized control trials regarding this left atrial strain. It's one which I am investigating at the National Health Institute in patients with ischemic stroke, large vessel occlusion, and we are examining their left atrial strain and seeing who develops this atrial fibrillation during the follow-up. So based only on the left atrial strain, it won't ever happen that we anticoagulate someone, but maybe, as I mentioned, in a multifactorial model, it can be implemented in a multifactorial model, like CHEST score. Maybe it could complete this this
could be one part of CHEDVESC.
Maybe if we can determine cutoff values, and if we can say based on a large number of patients that okay, if someone has a left atrial strain under, I say 10, then it will develop atrial fibrillation very more likely than those who are above this. Then maybe it can be implemented in a model, but not standing alone. So it won't ever happen, I think. We should also see the comorbidities of the patients, of course, because like in CHEST score and everything else. So maybe it can be a promising new method, but it opens our eyes that atrial fibrillation is only the top of the iceberg, and there are some underlying causes like this atrial cardiomyopathy, which can be already detected before the clinical development of this arrhythmia.
Okay, thank you.
Nice presentation, and when you showed at the beginning that you divided in the first study your patient into no detected atrial fibrillation and then detected atrial fibrillation, that how do you define atrial fibrillation, especially when you were talking about remodeling? So chronic persistent atrial fibrillation or paroxysmal atrial fibrillation is quite different, especially if I look the pathophysiological standpoint, especially thinking on remodeling, because if it's not persistent or permanent, I don't think there is too much remodeling, at least in the electrophysiological, but probably in terms of fibrosis as well.
Thank you very much for your question. It's yes, there were differing monitoring methods and differing types of atrial fibrillation, but in each study at the baseline screening, no one had in their medical history atrial fibrillation. So they were mostly paroxysmal atrial fibrillation developed during the follow-up period. And of course, we know that there is difference between the remodeling in one atria which has persistent atrial fibrillation and the other one which has paroxysmal, but this left atrial strain analysis is very promising to detect these subclinical cardiomyopathies which can already be present in those developing paroxysmal atrial fibrillation. So it's not like you don't have to have the end stage of this remodeling. It can also detect the subclinical way. So we are believing in it, and that's why we are using it also in paroxysmal patients.
It was an excellent presentation. I would like to start with an easy question. Global longitudinal atrial strain. This is the parameter you are recording, and you are offering this as a parameter for screening, if I understood correctly. How widespread the analysis of this parameter in echo laboratories in Hungary currently? Because I believe maybe it's not in the general characterization of cardiac function at the moment.
Yes, thank you for your question. It would be very nice if it could be, but at this time point we have only offline left atrial strain analysis, and we can use the software afterwards and putting the movies of the so the echocardiographic movies into a software, and it does this encountering the left atrial endocardial border, and afterwards it gives us the results. But yes, we don't use it nowadays bedside, but maybe if it will turn out that it is very useful and it can be implemented in a multifactorial model, maybe these echocardiographic machines could develop to be able to calculate it at the bedside immediately.
Thank you for the excellent presentation once again. I would like to add just that in case if you see some changes in the atrial strain, do you think there can be any early intervention that can prevent to develop the atrial fibrillation?
Yes, thank you very much for your question. I would have wanted to mention it also, but because of time I did not do it. But yes, maybe it would be very useful to detect this subclinical left atrial dysfunction, and maybe have a much stronger, stricter, maybe diabetes control in these patients, hypertension control, more frequent echocardiography examinations, and so on. So maybe it could not only predict atrial fibrillation, but also the other parameters which can cause atrial fibrillation could be followed up much stricter, maybe, based on this.
Could you please go back to the beginning of the first project slide?
This?
Yes. So if I understand it correctly, you have you want to measure the atrial strain to predict if atrial fibrillation will occur. Is this correct understanding?
Yes.
Okay. And when you are measuring atrial strain, can you first tell me what actually atrial strain is? What is this quantity?
Yes, it's so-called, so the myocytes are dots on the echocardiography, and the movement to each other, the movement of the myocytes is basically atrial strain. So how the contraction can occur in the atria. And if we know that during atrial fibrillation, there is no contraction of the left atrium, but in sinus rhythm it contracts, and maybe and this strain can show us how much it contracts. So maybe even in sinus rhythm, this contraction could be decreased, which is a strain.
So you would detect the decreasing contraction before you have atrial fibrillation.
Yes. So we cannot visualize it maybe only on the two-dimensional echocardiography, because we cannot see that. So performing an echocardiography on a patient during atrial fibrillation, we can see that it does not contract. Only this fibrillation can be seen. In sinus rhythm, we see on echocardiography that it contracts, and with our eyes we cannot see this. But this left atrial strain can tell us the value of this left atrial strain can tell us that it's already decreased, but the patient is still in sinus rhythm.
Great. How have you ever measured it yourself?
Yes.
And what is your experience with it? Because to my knowledge, ultrasound is really physician-specific. So the quality of the data and the reproducibility of the measurement really depends on the experience of the physician. So to be able to reproduce your own measurement results depends on your experience, and also like inter-rater agreement is a question. Yes. What is your experience with it? Do you have maybe any information on that, maybe your own experience or from the literature?
Yes, thank you for your question. From the literature, we know that you can only assess with the same software. So same in one. Seeing a study, we have one echocardiography machine, one software, and you have to use it during the whole project, because otherwise the inter-rater variability increases. But for this strain analysis, we only have to have a very good quality four-chamber apical view of the heart, and we have to put 3 dots to 3 points of the left
So
atrium.
you, the physician, places. So it's not the software automatically evaluating, but you have to place the, how you call it, fiduciary points.
Yes, but it has a so it.
Could we go to the slide where you have the video actually?
So we put the dots here, here, and here, but the software itself has an idea where you should put it, and maybe if it's not too wrong, you have to trust the software to decrease the inter-rater variability. So it's our consensus among those who do this examination that we first believe in the software, and only in those cases when the software maybe puts it here because of some problems, then we correct it. But otherwise, we trust the software because it's very because then it can decrease the inter-rater variability.
Okay, and your main variables were on one hand the strain, which is like the percentage change in length, if I understand it correctly, and you also had the strain rate, so the speed of this change. Yeah. So do you have like a normal range or normal value for these quantities, what you would consider a healthy value?
Yes, there are differing values in the literature because of so it's not so widespread yet to use it in the clinical settings. So that's why we don't have an exact value, but so we don't have a cutoff value, unfortunately. We would like to determine one.
Okay, so I think that would be a great idea to actually find out. And my other question is that the anatomical size or shape of the heart may have an influence on these values, what you expect. What is your opinion on that? So how do other parameters of the heart, anatomical or maybe other physiological parameters of the heart influence the values that you expect, let's say in a healthy person?
Maybe it's very great because it's not that much depending maybe on the fluid so how much the hyper or hypovolemia, it does not affect it that much. It's sad, but maybe the left ventricular function affects it very much. So if left ventricular function is decreased, even without atrial fibrillation, we will see a decreased left atrial strain. So this left atrial strain can be used better in those who do not have maybe heart failure. So in those who have healthy heart. So it affects, I think. And also the mitral valves abnormalities, maybe mitral insufficiency or mitral stenosis. Yeah.
It's a practical question that if you did this personally, then how long is to make this measurement? So because how long does the whole echocardiography, how long does it take to you to do one single, and how long this single part? How much does it elongate the examination?
Yes, one echocardiography exam, if we do not have a severe VCUM or something which we have to quantify, then it takes approximately 10 to 15 minutes. And afterwards, to put it in the software, it takes 5 minutes, and to have the results 1 or 2 minutes, so very quick, I think. Maybe it prolongs the whole, if we would use it bedside, it would prolong the whole echocardiography exam with 7 minutes, maybe maximum 10 minutes.
I would like to have one more question. I would like to ask you that this parameter can be used maybe to predict some other disease than atrial fibrillation.
Yes, thank you for your question. It's a very great question. Maybe also it was assessed during. So this we have this heart failure with preserved ejection fraction when we have a good ejection fraction, but still the patient has heart failure symptoms and elevated NT-proBNP. And in those, we say they may have a diastolic dysfunction, and in a diastolic heart failure, it can be also very useful to detect maybe someone after PCI who has a good left ventricular ejection fraction but still develops the symptoms of heart failure, we can assess this left atrial strain and maybe have a stricter follow-up or administrate some drugs earlier. So it can be useful, and they are not using it in practice, but there are some studies already on diastolic dysfunction and this left atrial strain.
I would like to continue along this direction, hemodynamic alterations in the heart and the cardiovascular system in association with your parameter, which is quite convincingly associates with the prediction of atrial fibrillation for the future. But I'm wondering if on the basis of your literature studies and also on the studies that were involved here, whether there were distinctions among the patients in simple parameters like blood pressure, systemic blood pressure, or more importantly, if data were available for precapillary wedge pressure, wedge pressure, which may also associate to left atrial filling pressure, if I am not mistaken. So, and that might have a direct effect on left atrial strain and left atrial expansion and the mechanical function of the atrial cavity.
Yes, thank you for your great idea. It was not, so this wedge pressure was not investigated in these studies. We did not have data on it, but yes, of course, hypertension was, and in some studies, those who developed atrial fibrillation during follow-up were more likely to have hypertension. So the prevalence of hypertension in those was higher in 3 studies.
Mm-hmm. Okay, so if we abandon now a little bit cardiovascular hemodynamics, what would be the next clinical parameter that you potentially would involve in your model to predict future atrial fibrillation, not only atrial fibrillation, but neurological symptoms like thrombosis?
So hemodynamic parameter,
not necessarily hemodynamic.
Maybe I would also add maybe the left atrial appendage morphology, and together with this morphology and the left atrial strain, we could. So we all know from studies from the CTs and MRI that there are some morphological types of left atrial appendage which are more likely to develop thrombi, and maybe we could use it together with left atrial strain. That was the first that came to my mind, but
blood coagulation parameters.
Sorry?
Blood coagulation. Would
yes,
they also make sense to take into consideration?
Yes.
Or other general characteristics like body mass index or diabetes, would they make sense to consider?
Yes, maybe we could do subgroup analysis, because diabetes alone also has a huge impact on atrial cardiomyopathy. So there are some subclinical alterations in the left atrium on the cell level in those with diabetes, and that's why maybe it can alter these strain parameters already in sinus rhythm. So yes.
You were specifically referring to HFpEF and diastolic dysfunction. I was very happy to hear that from you, not by asking, but by presenting by yourself. In any of these studies, did the investigators pay attention to diastolic dysfunction?
No, in these included studies, no, because we basically looked for studies with patients without heart failure. So we know from previous studies that heart failure affects left atrial strain. So that's why we excluded those who
systolic heart failure or diastolic?
Both we excluded, yes. So we don't have here patients, but as I did the research, I read very many papers on this diastolic dysfunction and left atrial strain.
You did very well. Thank you very much.
Hello. Thank you very much for your presentation. It was very interesting. Maybe my question will be kind of stupid one because I'm very far away from the ultrasound method. But It's the question that related to the performing this measurement. How sensitive is it? I mean, how the changes in the place where you start your the measurements influence on the result. I mean, if it will be change for 1 centimeter or from a little bit different angle, how much it may influence on the result in the interval from normal to pathology?
Yes, thank you for your question. It's very important because that's why I thought that we have to have a very good quality apical four-chamber view movie from the heart, and we say in cardiology amongst the echocardiographies that it cannot be foreshortened. Foreshortened means that the left ventricle will have another shape, and if we see this foreshortening on the echocardiography, it will be a bad quality of left strain analysis and bad results will be, yes. So
it means that you will not get actually the results.
Yes, because of foreshortening, maybe we have another shape, the left atrium, and that's why the left atrial strain is also altered on the measurements.
Yeah, but if the person, for example, if you compare person with obesity, for example, and a slim one, and a little bit their change the angle, for example, does this influence too much on the result? No, what's the interval from normal, from where you will count it as a pathology? Can these changes in millimeters, centimeters influence on that?
I think yes, they can influence it, but it's my opinion. I don't have this data here. And maybe so we have only those can have these pictures for strain analysis who can perform echocardiography very well. So it's very important to be a very experienced echocardiographist, at least to be able to have these good quality pictures. So it's very important, yes.